Welcome to Chapter 31, Nursing Management, Patients with Endocrine Disorders. Pituitary disorders. Hypersecretion is the most common cause of pituitary disorders. It involves hypersecretion of ACTH that leads to Cushing's syndrome, or oversecretion of growth hormone leading to acromegaly or giantinism. Hypersecretion of all of the anterior pituitary hormones causes the thyroid gland, the adrenal cortex, and the gonads to atrophy. Hyposecretion of antidiuretic hormone results in diabetes insipidus, and hypersecretion of ADH leads to the syndrome of inappropriate antidiuretic hormone, or SIADH. Most of these disorders are usually caused by a pituitary tumor, and pituitary tumors are usually benign. Most pituitary disorders are treated with medications and/or surgery. Diabetes insipidus. Diabetes insipidus, or DI, is a deficiency of antidiuretic hormone that is characterized by excessive thirst, polydipsia, and large volumes of dilute urine. There are three types of DI: neurogenic, which results from damage to the posterior pituitary gland; nephrogenic, which results from drug-related damage to the renal tubules in the kidneys; and psychogenic, which results from excessive water intake, often due to psychotropic disorders. The treatment goals of diabetes insipidus are to replace antidiuretic hormone, ensure adequate fluid replacement, and to identify and correct the underlying pathology. Nursing management is aimed at including maintaining an adequate fluid volume, monitoring the patient's weight, the administration of vasopressin or DDAVP, monitoring vital signs, and monitoring the patient's intake and output, and monitoring for electrolyte imbalances. Which of the following nursing diagnoses should be prioritized in the care of a patient with diabetes insipidus? Answer C. Deficient fluid volume. Without the action of antidiuretic hormone on the distal nephron of the kidney, an enormous daily output of very dilute urine occurs. Signs and symptoms of fluid volume deficit occur as patients are unable to compensate for the massive urinary loss. Incontinence is not a priority problem in these patients. Syndrome of inappropriate antidiuretic hormone, or SIADH. SIADH can be caused by malignancy, severe pneumonia, tension pneumothorax, head injury, brain tumors, and infections. Patients with this disorder cannot excrete diluted urine, and they develop dilutional serum hyponatremia, which is low sodium in the serum. Medical management includes identifying and eliminating the underlying cause. Nursing management includes close monitoring of fluid intake and output, daily weight, urine and blood chemistries, and neurological status. Hypothyroidism. The most common cause of hypothyroidism is autoimmune thyroiditis, Hashimoto's disease. Hashimoto's disease is where the immune system attacks the thyroid gland. Manifestations are divided into early and late symptoms and represent slowing of the metabolic processes in the body. Hypothyroidism is treated with levothyroxine, Synthroid, or Levothyroid, and that you adjust the dose according to the patient's serum TSH, or thyroid stimulating hormone. Nursing priorities include monitoring vital signs and cognitive levels in your patients, preventing medication interactions, and managing myxedema if it develops. A complication of hypothyroidism is myxedema. Myxedema is the accumulation of mucopolysaccharides in the interstitial tissues, which leads to non-pitting edema in the patient. This can cause pericardial and/or pleural effusions. Myxedema is dangerous and can lead to coma and death. It's a medical emergency that is manifested by decreased respiratory drive, cardiovascular collapse and shock, and aggressive therapy is warranted, and still mortality is high in spite of therapy. Hyperthyroidism. Hyperthyroidism is the second most common endocrine disorder after diabetes mellitus. An overproduction of T3 or T4 from the thyroid gland manifests itself by greatly increasing the client's metabolic rate. Hyperthyroidism is usually associated with an enlarged thyroid gland, often known as a goiter. Graves' disease is a common cause of hyperthyroidism. Graves' disease is an autoimmune disease that results in the binding of antibodies to TSH, or thyroid stimulating hormone, which causes overproduction of T3 and T4. Women are 8 times more likely to be affected with hyperthyroidism than men. Symptoms of hyperthyroidism may appear after emotional shock, stress, or an infection. The signs and symptoms are associated with an increased metabolic rate, such as nervousness, emotional hyperexcitability, palpitation, increased heart rate, heat intolerance, excessive sweating, flushing, weight loss, and osteoporosis. Patients with hypothyroidism often exhibit exophthalmosis, which is bulging eyes due to fluid behind the eye. Hyperthyroidism is treated with radioactive iodine, antithyroid agents, and surgery. Is the following statement true or false? The patient with hyperthyroidism is prone to constipation and apathy. The answer is false. Hyperthyroidism is characterized by a hypermetabolic state. This is likely to cause irritability, restlessness, and diarrhea. Nursing process, the patient with hyperthyroidism. Assessment focuses on symptoms related to accelerated or exaggerated metabolism. Goals and interventions for these clients focus on improved nutritional status, improved coping ability and self-esteem, maintenance of normal body temperature, and absence of complications. Medical management for patients with hyperthyroidism is often a combination of drug therapy and surgery. Medications include radioisotope iodine 131 therapy. This destroys overactive thyroid cells. It's a tasteless medication that often cures the problem after one dose, and some patients do need a second dose. It's not common to need a third dose in radioisotope iodine therapy. Initially, radioisotope iodine therapy may cause an acute release of thyroid hormone, which may cause an increase in the symptoms. This is often referred to as thyroid storm. Monitor the client for signs of thyroid storm, which include tachycardia, palpitations, hypertension, and use a beta blocker orally if at all possible to manage this problem. Also, it's important to do a pregnancy test on females, as this medication is harmful to the fetus. Antithyroid drug therapy is used to inhibit one or more stages of thyroid hormone synthesis and is another mainstay of medical management for hypothyroidism. Propylothiuracil, or PTU, or methimazole, tapazole, is used until the patient is euthyroid or normal. These medications block the conversion of T4 to T3, as T3 is about 4 times more potent than T4. If no results with these medications, then the client is scheduled for a thyroidectomy, which is a removal of the thyroid gland. Thyroid tumor, or hypothyroidism. Thyroid tumors are often accompanied by a goiter. Presentation depends on the etiology of the growth. Treatments include medications and surgeries, and nursing priorities after a thyroidectomy include area maintenance for obstruction, pain management, fluid balance, and monitoring for complications, especially hemorrhage, which can happen behind the dressing and leak beneath the neck. Also, it's important to monitor the patient for hematoma formation, which can cause an airway problem, edema of the glottis, which can cause an airway problem, and hypoparathyroidism, which may produce hypocalcemia. Hyperparathyroidism is characterized by having excessive parathormone, or PTH, leading to a markedly increased level of serum calcium. Recommended treatment of primary hyperparathyroidism is the surgical removal of the abnormal parathyroid tissue, a parathyroidectomy. Nursing management involves hydration, encouraging mobility, administering nutrition and medications, providing emotional support, and observing for and managing the hypercalcemic crisis that may present itself. Hypoparathyroidism results from hyposecretion of the parathyroid glands, leading to low levels of PTH, which eventually results in hypocalcemia and hyperphosphatemia. The most common cause is surgical removal of parathyroid gland tissue during thyroidectomy. The major sign of hypoparathyroidism is tetany, which is a general muscle hypertonia, with tremor and spasmodic or uncoordinated contractions. The treatment goal of hypoparathyroidism is to increase the serum calcium level to 9 to 10 milligrams per deciliter. Nursing interventions focus on early signs of hypocalcemia and anticipating signs of tetany, seizure, and respiratory difficulties. Which of the following assessment findings in a post-thyroidectomy patient would be suggestive of tetany? The patient complains of diffuse muscle pain. The patient complains of numbness and tingling around his mouth. The patient's oxygen saturation is 90% on room air. The patient is oriented to person and place, but not to time. Answer: the patient complains of numbness and tingling around his mouth. Signs and symptoms of tetany include numbness and tingling, which may be present in the patient's extremities or around the mouth. Confusion, pain, and changes in respiratory status are not characteristic of tetany. Pheochromocytoma. Pheochromocytoma is a benign growth of a catecholamine-secreting tumor inside the adrenal gland that results in hypertension. Surgical removal of the tumor is necessary. Nursing management of the patient includes close monitoring of the patient's vital signs, especially heart rate and blood pressure, and monitoring of mental status, acute EKG changes, arterial pressures, fluid and electrolyte balances, and blood glucose levels. Addison's disease. Addison's disease is a primary adrenocortical insufficiency that occurs when adrenal cortex function is inadequate to meet the need for cortical hormones. Risk factors include surgical removal or infection of the adrenal glands and abrupt cessation of exogenous steroid therapy, in other words, withdrawal of steroids that the patient is on. Characterized by muscle weakness, anorexia, gastrointestinal systems, fatigue, emaciation, skin pigmentation changes, hypotension, low blood glucose, hyponatremia, and hyperkalemia. Nursing priorities include maintaining fluid balance, minimizing stress, and promoting self-care. With disease progression, an Addisonian crisis can develop. Addisonian crisis is manifested by acute hypotension, cyanosis, rapid and weak pulse, rapid respirations, circulatory collapse, and shock. Other signs include nausea and vomiting, headache, abdominal pain, and diarrhea. Addison's disease is diagnosed with early morning serum cortisol and ACTH levels, and it's treated with corticosteroids such as hydrocortisone or Solucortef, and managing shock, administering fluids, and monitoring vital signs. Cushing's syndrome. Cushing's syndrome is often caused by overuse of synthetic corticosteroid medications. A rare cause is a tumor of the adrenal cortex. The disorder is characterized by high levels of serum cortisol. Signs include an arrest of height, obesity, musculoskeletal changes, glucose intolerance, a buffalo hump, and a moon face. Thin, fragile skin also develops. Nursing priorities include promoting safety, preventing infection, promoting skin integrity, and promoting body image. If Cushing's syndrome is caused by corticosteroids, then an attempt is made to reduce or taper the medication to the lowest dose necessary to treat the underlying disease process. Additionally, it's important to remember to never abruptly withdraw steroids from your patient. If the patient becomes NPO for whatever reason, then you must replace the oral steroids with an IV replacement to prevent a Cushing's type reaction in your patient. Is the following statement true or false? If a patient has been taking corticosteroids for several years to treat an autoimmune condition, the patient is at an increased risk of developing Cushing's syndrome. True. Cushing's syndrome is often caused by the overuse of corticosteroid medications. When combined with endogenous steroid production, the patient is likely to have dangerously elevated levels of corticosteroids. Primary aldosteronism. PA, or Conn syndrome, is a condition in which the adrenal glands produce too much aldosterone because of a hyperplasia or a tumor. This results in a profound decline in the serum levels of potassium, hypokalemia, and hydrogen ions, which produces metabolic alkalosis. Treatment usually involves surgical removal of the adrenal tumor through an adrenalectomy, which is the removal of the affected adrenal gland through a surgical incision in the flank.